I just want to, before as I start here, I'd like to mention that this is the second time I presented at GISday, and this is a really great opportunity for networking and connecting with other people who are doing similar work. And also wanted to thank Cynthia for organizing this day. Anybody who's ever needed to work with spatial data within the university system, Cynthia Dietz and Gary Strike are incredible resources. So whenever you have a question or trying to figure out how to solve some kind of spatial problem, both Cynthia and Gary are really, really fabulous resources and can connect you up very quickly with what's available. So they've been very helpful in the work that I've done over the last 10 years, in fact. So what I'm going to present today is some of the preliminary work we're doing at the Winnipeg Regional Health Authority. Let me just get this set up. So at the Health Authority, I'm the senior epidemiologist. I've been working there for 2 years. And prior to that, I worked for agriculture with the chief veterinary office, and then before that with Manitoba Health. And in all those places, I did quite a bit of work with GIS and spatial epidemiology. So what I want to do is first talk about the public health context in which we work, in which we do our mapping. So there is a most times when you get health advice about how to take care of your health, people tell you to exercise, eat from the 4 food groups, and those kinds of personal kinds of things, pieces of advice. But there was a really interesting report that came out in 2004 that Roy Romanow was the lead author on, and it was called Improving Health for Canadians, and they kind of turned this on its head a bit. And so the advice they gave to Canadians for maintaining healthy were things like, don't be poor. So if you have a choice in life, don't grow up in a poor family or in a poor neighborhood, because this is really quite bad for your health. They also suggested that you should get a good start in life, so make sure your parents stimulate you, that you go to a good preschool, that you're read to a lot as a child, you have good nutrition, and make sure you graduate from high school, so you're in a neighborhood where kids graduate from high school at a high rate, and get a job. Make sure you are not unemployed, because being unemployed is bad for your health, and pick a good community to live in. Don't live in a poor neighborhood where there's lots of crime and lots of gang activity happening. And live in quality housing. Don't live in poor housing, because that's bad for your health. And look after yourself. So make sure you take your spring break. You take trips to Big White and go skiing, or go hiking in Banff or in the American Southwest. In the summertime. Make sure that you get outside and do a lot of things that are good for your mental health and physical health. And most importantly, pick whether you're going to be male or female, because the fact, you have to pick your poison here. Women tend to live longer than men, but women report being less healthy than men. Okay, so which do you want? Live longer or complain more about your health, or those kinds of things. So pick your gender. That's an important consideration. So, the point I'm making here is that in public health, the thing we're really interested in is looking at not at individual characteristics and behaviors as much as the broader determinants, upstream characteristics that affect our health. The things that things that I've just described, which actually determine whether you make good choices or poor choices in life, things that are out of the control of the individual. And we're really interested in trying to prevent people from getting sick in the first place, so they don't have to end up in the healthcare system. So that's the area that I work in the healthcare system. So the other thing is that public health also focuses on the big picture of what affects population health. So we're really interested and concerned about health threats to our population that are now occurring because of large globalized forces. I'm talking about things like global warming, the rapid transmission of diseases from one side of the world to the other, increasing worldwide livestock density and the spread of novel zoonotic diseases. Probably you may not know this, but about 2/3 of our emerging infectious diseases come from animals. Rapid urbanization in Canada and around the world, aging of the population, environmental degradation, and so on. And all of these are large, big, huge forces which are affecting the health of the population, independent of the actions of individuals. On the map on the right is that's a map I did of West Nile virus in 2003 when it hit Manitoba. As you can see here that when we're talking about West Nile virus in Manitoba, we can see that it was part of a much larger epicenter of of a dynamic disease transmission dynamic that was happening at the North American level, and that what was happening in Manitoba was just on the edge of that. So GIS here can really show us that what's happening in Manitoba is just part of a larger globalized transmission dynamic. And this is just came out in the paper I think last week. Now they've discovered a new mosquito now, which is now appearing in British Columbia, and it carries dengue fever. So we usually think of dengue fever only occurring in tropical areas, in Cuba, in the West Indies, and places like that. Now we're facing the specter of having some of these tropical diseases migrating into Canada because of global warming. So I would argue that GIS and looking at things spatially are going to allow us to actually understand these dynamics in a much more fundamental way and in a scaled up way, and help us address globalized issues as they health issues as they begin to hit us here in Canada. As you may not know, that malaria was actually quite big in Canada at the turn of the century in southern Ontario before they drained all the swamps and things around the farmland. So we tend to think of those diseases being over there, but they're just ready to come here anytime. So a lot of our work that we do at the Winnipeg Regional Health Authority and public health is we focus on the impacts of the built and social environments and how these affect public health. And you know, if you think about focusing on the built environment, this has a long history in public health. In the 1850s in Britain, in France, and then around the turn of the century in North America, there was a huge sanitary movement which focused on restructuring the urban environment to prevent the spread of infectious diseases. And so this involved extensive infrastructure required to deliver clean water, remove sewage and garbage. And I think that probably the lowest point in human life expectancy was around the beginning of the 1800s in Britain. I think the average life expectancy was like 22 years of age. It was much lower than existed for hunters and gatherers because conditions were so bad in these urban centers, primarily because there wasn't clean water and the sewage wasn't being taken away from the city. So today we're faced with another urban crisis with regard to our urban design, because we now have car-oriented urban infrastructure which promotes the development of chronic disease by systematically discouraging people from being physically active and encourages people to eat too much. So when you go to the gas station, you know, the gas stations are making all their money from food now, not from gas. That's their new business model. So we're seeing high rates of obesity, diabetes, and other lifestyle issues just skyrocketing in our urban areas. These two maps here illustrate the challenges we have faced over time and the power of the urban environment in creating conditions for poor health. So the map on the left is a pin map of smallpox cases that the Winnipeg Public Health Department put together around 1910, 1920, showing the highest number of cases occurring in the North Point Douglas area. Shows you don't need computers to do public health mapping. This is a pin map that the Public Health Department put together and was very effective, I think, in helping them understand what was going on with that disease. The map on the right shows high rates of diabetes 90 years later occurring in exactly the same location. So infectious diseases, new immigrants from Eastern Europe, 100 years later, same area, same part of the city, chronic diseases affecting primarily First Nations. So focusing on the impact of the built environment, we're concerned with describing and mapping and addressing many aspects of how Winnipeg operates. Urban design, housing quality, transportation networks, the urban foodscape, and the quality of our natural environment. And another area that's really important for us too, and has become a priority for the Winnipeg Regional Health Authority, is the whole issue of health equity. We're concerned why some populations are less healthy than others across the city, and this is a strategic priority of the board of the WRHA. And so this is where GIS can play a very powerful role, because it can help us describe the geographic inequalities in health across the city and show where those things are occurring. So the work I do, I work in public health surveillance. This is considered to be one of the core science of public health. It's the art and science of describing the magnitude and location of health issues and identifying the causes. So not having good surveillance is like driving down the road without your headlights on. You don't know where you're going. You can't anticipate what you're going to bump into and so on. So if you have good surveillance, you have a sense of what the health landscape, how it's occurring, how it's being activated, and what's coming at us in the future, and allows us to be much more strategic with our limited resources. So when we're doing public health mapping, we're interested in looking at the sole area of place-based surveillance, what's happening in certain places versus others. And basically, we're interested in mapping everything, because public health is really about how society operates and how those social dynamics affect the health of the population. This is a picture of this map on the left is probably one of the original public health maps. It was the Broad Street Pump done in 1850. This is John Snow. He was cholera was coming across from India into Europe in the 1850s, and John Snow was a medical officer in downtown London, and there was a lot of cases of cholera happening. So he actually pin mapped the cases of cholera and the location of water pumps in local neighborhoods, and found that a lot of cases of cholera were congregating around the Broad Street Pump, which is there's a picture of that on the right. And the story goes that it removed the handle from the Broad Street Pump and the cases of cholera diminished. The story is not as simple as that, but it's a nice example of how public health mapping can be one, low tech. You don't need Esri to do your mapping, and secondly, you can use the map to make strategic decisions about health interventions. Okay, I want to talk about the GIS infrastructure that we're building at the WRHA. I'm going to talk about this a little bit later in the presentation, but we're having to do this on almost no resources. Even though the WRHA is the Winnipeg Regional Health Authority is one of the biggest employers in the province, if not the biggest. It has a budget of billions of dollars. In public health, we're actually the poor cousin in the organization. Most of the money goes into high-tech medicine and providing healthcare services. We're trying to build the idea of preventing disease from happening in the first place, and so we don't have much of a budget. So when we build GIS infrastructure, we have to do it on very small dollars with very few resources. So here's just a broad overview of what we're doing. We're building our place-based surveillance capacity, and this consists of a comprehensive spatial repository of key population health data, methods to integrate these data into our routine surveillance processes, and then strategies to serve map outputs to end users inside and outside of the organization. The two things I'm going to demonstrate this morning, we're really focusing on how to move out interactive mapping applications to end users. Paper-based maps are really great and have their role, but for a dynamic surveillance, we want our users to be able to interact with the data and work with it intelligently and gain new knowledge by having an interactive mapping application. So the two approaches that we're working with, which we're using a thin client mapping approach, which is using Google Earth, which I'll demonstrate for you, and then we're using a simple web-based mapping approach as well. Our spatial repository, we're building quite a large spatial repository for Winnipeg. We're trying to have this data at our fingertips so we can quickly map and respond to emerging public health issues. As you can see, we're collecting information on administrative boundaries, wide range of points of interest. This is like recreation facilities, housing, financial institutions, landscape, things like roads, bike infrastructure, waters, parks, green space, population characteristics, age structure, income, ethnicity, and health outcomes and utilization, chronic disease patterns, lifestyle habits, injuries, and things like that. We're also working on building some composite indicators. We include things like walkability index, identification of food deserts and food swamps, and so on. And I have to point out that the task of acquiring a lot of these key data sets is pretty challenging. We have to go out to many key community partners who often can't easily provide us the data we want, or are often reticent to do so and don't understand why we want that data for our work. So it's a lot of work assembling this data. For example, when we built our school layer, we actually went to a PDF that Manitoba Education had online and manually entered all of the schools in Winnipeg to get the data we needed for that layer. Similarly, we use the yellow pages quite a bit for some of our commercial points of interest. Okay, so I'd like to illustrate some of the web-based mapping we've been experimenting with over the past couple of months, and this is very, very preliminary at this point. We're just prototyping this idea up. We're calling it the Neighborhood Explorer Toolset, or NET, and it's an experimental web portal to serve out spatialized health, social, and demographic data out to our own staff, and then hopefully to our community partners to facilitate place-based analyses. And it consists of two major ways of serving the data out. One is the turnkey web-based maps, which has some built-in geoprocessing capacity, and then a Google Earth-based custom map builder, which will allow end users to build their own custom maps in Google Earth. So I'm going to see if this will work for this technology this morning, and hopefully it will. Usually when the technology doesn't work is in situations like this, and then I have to tell people what you would have seen on the screen is this, but we'll see what happens here. So here's our front end, and basically what I'm going to do is I'm going to demonstrate a couple of our web-based applications. I'll start with looking at some built environment indicators. So what we did was we built a walkability layer, which is a composite index based upon street intersection density, population density, and the concentration of amenities such as stores, restaurants, banks, recreation centers, and so on. And I'm going to turn on the neighborhood layer here. And I'm going to zoom in closer within the city here. And the darker the color is, the more walkable a neighborhood is. So if I zoom in to say, well, I'll look at the neighborhood that I live in, for example. And if we zoom into the Wolseley neighborhood and take a look at the base map underneath, we can see that it's a very tight intersection of streets which are close to a lot of commercial amenities. And so that's why the Wolseley neighborhood has got quite a high walkability score. And then what's nice about this application, and we want our end users to be able to do this, is that we can actually bring our street view down, Google Street View down, which is integrated into this application, take a quick look and see what it looks like on the ground. So we can see here we are in the Wolseley neighborhood, lots of sidewalks, lots of amenities. There's a church. If you go down the street, there's some restaurants and bakeries and things like that. So this is an area that has a very high walkability score. Alternatively, if we go to someplace like down to say Lindenwoods, for example, we can see that the street intersection density is not as tight, much lower population density. And if we use our Google Street View and drop down into Lindenwoods, we can actually see then that this neighborhood actually is quite different than the Wolseley neighborhood. There's no sidewalks, very tough to walk, and there aren't a lot of destinations in that neighborhood that you would walk to a store to buy food and things like that. So this just shows this idea then that you can use a map then to actually understand spatial patterns and then ground truth it by using some tool like Google Street View. We go back to another application here, primary allocation model. Oops. So this is a mapping application we're developing to support our nurses and figuring out how to restructure their nursing practice so their nursing practice can be much more place-based. And so they need a lot of information on what's going on within a particular neighborhood, things like income, First Nation population, recent immigrants, things like that. So what we can do is we can turn our layers on and off. So here we'll look at single-parent families. So you can see the highest rates of single-parent families are in the downtown area. We can look at immunization coverage and see the lowest immunization coverage rates are in the downtown area of the city. Ambulatory sensitive conditions, these are conditions where when people ended up in hospital when they should have gone to a primary care physician in the first place. And so this shows real issues then with our primary care healthcare system in Winnipeg and so on. We can click on a particular geography. These are WRHA facilities, and we can see this is Access River East. But the really neat thing about this tool is we can also do some geoprocessing. So, for example, I'm going to zoom again into around my neighborhood again, Wolseley, and I'm going to turn this off, turn the neighborhoods on, zoom in. So here's the Wolseley neighborhood. And let's say we want to know how many people lived in this particular area of the city. So we've got a population layer loaded on here. So what we can do is we can use our data summary tool, and we're going to summarize by population, and we're going to do a custom shape, and we're going to create a shape for this area here. And let's say that's the area we're interested in. And close that. And you can summarize this selection. And that will tell us that in this area there's a population of 7,502 individuals, and we can see that there's 1,567 individuals who are less than 20 and 111 who are greater than 80 years of age. And so you can see this could be really useful then if you're planning public health services, how many people are in my catchment area or an area that I'm considering to provide service to, or during an emergency response situation if we need to buffer around a particular kind of risky event such as an oil spill or an explosion and things like that. We can quickly get a sense of what's going on. And we can do the similar buffering to see how many recent immigrants there are, how many First Nation individuals there are, and so on. So that's what's neat about this approach. Okay, the other thing that I wanted to show you then was that we're building on the capacity for staff and our partners to build their own custom maps in Google Earth. And so what I'm going to do here is we go to Google Earth. We got a blank Google Earth. How much time have I got left? Not too much? Okay, so I'll finish this up quickly then. Okay, so here we got our Google Earth loaded, and if we go to our Google Earth mapping, we can add our administrative boundaries to Google Earth. So add community areas. So by clicking on our web page, we can add our administrative boundaries to Google Earth. If we wanted to add, say, income data, we can add population characteristics, and we can add our median family income to Google Earth. And so now we've got a map in Google Earth that's been customized that'll now allow end users then to go in and interrogate the data. They can click on any of the small geographies here to get the income levels. They can copy this map out to a PowerPoint presentation. And so what we're intending to do is build multiple layers into a catalog online that users then can load into Google Earth to create their own custom maps. And again, you also have the ability then to use Google Street View to go down and interrogate or ground truth to look at what you're actually dealing with. Okay, so I'm just going to finish up quickly here then, since I don't have much time left. That's my wrong presentation. Here we go. Slide. So we've had a number of challenges and opportunities. I mentioned before that we are the poor cousin in public health. We have to build our solutions with very few or no resources. One of the issues when you're mapping data and you're pushing it onto the web is that you got to make sure that your data, you've got stable rate estimates happening. If you're doing small neighborhoods, you might have one or two cases which can elevate your rates and make people pay attention to an event kind of rates that really aren't that important. But the more important issue, obviously, is really around this whole issue of protecting confidentiality. When we push data up to the web for web-based mapping, we have to assume that data is never coming home. Okay, so we have to be very careful about the data we put out there for people to consume, and so that creates real issues. And if you've got trying to publish small area estimates for health events, or maybe only 300 cases of syphilis in the city of Winnipeg, how do you portray those at the neighborhood level in a way that's meaningful? And acquiring our upstream data can be quite challenging. I've alluded to that earlier. Bringing all the data we require for our work is unlimited resources is quite challenging. And finally, one thing we found really, really powerful and useful is making key collaborative relationships with the University of Manitoba, University of Winnipeg, and Red River College, and especially with the Red River College training program, bringing Red River College students in for their practicum experiences has really helped us jumpstart the work that we do. And so in conclusion, GIS is a powerful tool in public health context. You can take tabular data, make it meaningful and useful to people. And interactive tools, I think, can really make that come alive in real ways for planning and program design. And I think you can do a lot without a lot of dollars. So thank you.